Ladies and gentlemen, distinguished guests, esteemed researchers, and esteemed colleagues, it's with great pleasure and honor that we welcome you to the International Symposium on Cardiovascular Sciences hosted jointly by PSG College of Arts and Science and PSG Institute of Medical Sciences and Research in collaboration with University of Cincinnati, College of Medicine, Center of Cardiovascular Research, United States of America. This symposium stands as a beacon of collaboration and innovation in the field of cardiovascular sciences. Today, we gather here to delve into the depths of cardiovascular research, exchange groundbreaking ideas, and foster interdisciplinary connections that will shape the future of cardiovascular medicine. With a distinguished lineup of speakers, researchers, and experts from around the globe, we are poised to explore the latest achievements, challenges, and opportunities in cardiovascular sciences. We invite the dignitaries to kindly take their seats on the dais.
We kindly invite the dignitaries to occupy the dais. As we embark on this intellectual journey, let us harness the power of collaboration, innovation, and determination to unravel the mysteries of the human heart and pave the way for a healthier future for the generations to come. Once again, a hearty welcome to all the dignitaries and participants of the International Symposium on Cardiovascular Sciences.
We begin this momentous occasion with a prayer song by the student from the Department of Carnatic Music, invoking blessings for our collective journey towards healthier hearts and a bright future.
Maitreem bachata akilak jetreem Maitreem bachata akilak jetreem Atmavadeva paranabhi pashyata yuddham tyajata spardham tyajata tyajata pareshva kramamakramanam Maitreem bhajata akilak jetreem Janani prithvi kamadukhaste Janako devah sakala dayaluhu Damyata datta dayatvam janata Damyata datta dayatvam janata Shreyo bhuyat sakala jananam Shreyo bhuyat sakala jananam Shreyo bhuyat sakala jananam Shreyo bhuyat.
Welcome is the word that greets us at the threshold of every experience, says Margaret E. Sangster. Now, let's extend a warm welcome to Dr. Victor Arogyadas, Head of the Department of Biochemistry, PSG College of Arts and Science, to greet the august gathering.
PSGCAS, Dr. T. Kannayan sir. I am so grateful to welcome Dr. D. Brinda, Principal, Specialties Hospitals, Dr. Sudha Ramalingam, Director, Research and Innovation, PSG IMS and R, and Vice Principals of PSGCAS, Dr. Angraj, Dr. Jayanti, Dr. M. Umarani. A very special welcome to the following guests from USA and speakers of the day, without whose wholesome presence today, this event would not be possible. Of Cardiovascular Disease, University of Alabama, Birmingham, USA, Dr. Timothy McKenzie, Professor, University of Colorado, Anschutz Medical Campus, USA, Dr. Shyam Bansal, Associate Professor and Vice Chair, Heart and Vascular Institute, Pennsylvania State University, USA, Dr. Hossein Ad Ali, Professor of Medicine, Cardiology and Pharmacology, Director of Center for Molecular Cardiology, Northwestern University, USA, Dr. Satyamangala Nagaprasad, Professor, Cleveland Clinic, USA, Dr. Rajashekaran NS, Associate Professor of Pathology and Medicine, Cardio, Neuro, Aging and Redox Signaling Laboratory, University of Alabama, Birmingham, USA, Dr. Suresh P. Damodara, President, American Heart Association, Midwest, Florence, Vermont Heart and Vascular Institute, Kentucky, USA. A very hearty welcome to each one of you. It is our honor to welcome American Heart Association consultants, Dr. Sachin V. Menon, Consultant Regional Director, AHA, Thrissur, Kerala, India, Dr. Vishwas Sathe, Quality and Certification Consultant, AHA, Mumbai, India, Mr. Sriman Ashok Kumar, Consultant, AHA, Kottayam, Kerala, India. With great pleasure, I welcome the co-conveners, organizing secretaries, organizing coordinators, various committee members of PSGCAS and PSG IMSR. Also, I welcome HODs and faculty members of organizing departments and other departments of PSGCAS, HODs and faculty members of other PSG institutions, principals of other PSG institutions. A very warm welcome to the following persons: faculties and research scholars and participants from various other institutions from Tamil Nadu state and other states of India, all our alumni, the research scholars, student registrants, poster presenters and participants, members of the press, each and every one who had assembled here, a hearty welcome. Thank you.
Thank you, sir, for a congenial welcome. As we light the lamp of knowledge, let's illuminate the path of progress and discovery. With these profound words echoing in our hearts, I invite our distinguished guests on the dais to join us in the tradition of lighting the lamp, symbolizing the illumination of knowledge and the beginning of our symposium journey. Let us together ignite the flame of learning, inspiration, and collaboration.
Thank you, dignitaries, for the auspicious beginning. In the spirit of wisdom and enlightenment, it's my pleasure to kindly request Dr. B. Ramesh, Associate Professor from the Department of Biochemistry, PSG College of Arts and Science, to deliver the preamble of the event.
Distinguished dignitaries on the dais, esteemed colleagues, fellow researchers, and student friends, good morning to all gathered here. It's with great pleasure and honor to welcome each and every one of you to the International Symposium on Cardiovascular Sciences, organized by PSG College of Arts and Science, a world-renowned institution that has diffused dynamism and knowledge to several learners over 75 years. In an era marked by unprecedented advancements in medical research and technology, heart disease, stroke, and vascular diseases remain the leading cause of global mortality. It demands our collective expertise and focused efforts. In the year 2017, cardiovascular disease was responsible for 27% of total deaths in India. And within India, the rates of cardiovascular disease vary markedly, with highest in states of Tamil Nadu, Punjab, and Kerala. Cardiovascular disease struck Indians a decade earlier than the Western population. For Indians, particular cause of concern in cardiovascular disease are early age of onset, rapid progression, and high mortality rate. With this historical background, we were fortunate enough to identify a unified forum for cardiovascular research community to connect outstanding scientists nationally and internationally. The outcome is, today, the life science departments of PSG College of Arts and Science, namely biochemistry, microbiology, biotechnology, nutrition, clinical nutrition, and the Department of Hospital Administration, in association with PSG Institute of Medical Sciences and Research, have conjoined with the University of Cincinnati, United States of America, to conduct the International Symposium on Cardiovascular Sciences. This initiative aims to provide latest insights and advances in the field of cardiovascular research. To add a cherry on top of the cake, this symposium is the first one of its kind happening in the Manchester of South India, Coimbatore, which brings together frontiers and leaders focusing on imparting continued efforts to understand the intricacies of cardiovascular science. The primary focus of this symposium is to foster international collaboration and promote knowledge exchange among scientific communities, among young researchers, and overseas learning experience for students. For this novice event, a team of international pioneering researchers in the field of cardiovascular research have come together to provide valuable inputs and spread knowledge among the knowledge seekers. We welcome the scientific community to benefit from the symposium and also to engage in an interactive session of pooling in ideas. Drawing to a close, let us work together and save millions of hearts through advanced cardiovascular research, because science is a magic that works. Thank you all. Have a great day.
Thank you, sir, for setting a profound tone for the symposium's discourse. With a steadfast commitment to excellence in healthcare, it's my privilege to extend a heartfelt invitation to Dr. J. Bhuneshwaran, Director of PSG Super Speciality Hospitals and PSG Institute of Medical Sciences and Research, to address the august gathering.
A very good morning to the senior faculty and the heroes of today's conference on the dais, and dear students and my other colleagues of the dais. If there is anything which is constant in science, it's change. In fact, when I entered a room where all the scientists, the cardiologists, many of them from our motherland, who have settled in US, the discussion started on risk factors. Let me tell you honestly, in India, if you look at the question of risk factors, the conventional risk factors, which the WHO has defined as the 8 conventional risk factors, being a male, being older, a hypertensive, a diabetic, a hypercholesterolemic, sedentary, and with a family history, lack of exercise, or the conventional risk factors which are known to lead to cardiovascular diseases. But what, after practicing over 35 years of cardiology in India, let me tell you, we do not know that whether conventional risk factors can give an answer to all the diseases, the spectrum of diseases what we see in our current clinical practice. A young lady, absolutely no risk factor, who is in her active reproductive age, gets an acute cardiovascular event, an acute myocardial infarction. You take her to the cath lab, you see a single thrombus sitting somewhere in LAD, and once you do a thrombosuction, it's a clean vessel subsequently. On the other hand, you see a 30-year-old man, again absolutely there is no risk factors, no conventional risk factors, no family history, nothing. He comes with unstable angina. You do an angiogram, you see diffuse triple vessel disease, small vessels. There's a lot of research being done in the so-called Southeast Asian population. This adds the countries of India, Pakistan, Bangladesh, and certain eastern countries like Indonesia. In fact, the cardiovascular curse, you can call it as a curse, is supposed to be on us, making us very vulnerable for cardiovascular diseases. But let me again tell you, because now we do angiogram left and right and center, we know the anatomy, and we do not have a straightforward answer for our diseases with whatever theory we know. That makes the conclaves or the symposia of such nature very, very important one. Very uniquely, we have the clinical cardiologists, we have the PhD scholars, we have the research scientists as a very unique gathering, wherein from the molecular level to clinical level, we will probably have an analysis of what is happening now, what can be done, and what can be done in the future to prevent this particular issue. We have to look into the environmental factors. We have to look into the toxic factors which we do not know, and we have to look into the vulnerability of the person and the genetic predisposition. So I'm extremely happy that the Department of Biochemistry, Madam Brinda, and our esteemed team of PSG IMSR, my dear colleagues, we are extremely excited to be a part of this symposia. I'm sure that students, please interact, because I'm very sure, like how some of you can be the same faculty years down who will be sitting here in this fora to deliberate the next generation of students. With this, I wish this function, wish this event, wish this symposia a very, very explosive in getting some solutions for the problem which we face. God bless. Thank you.
Thank you, sir, for your words of presenting the real scenario about cardiovascular health and your dedication to advance medical sciences which inspire us all. The roots of education are bitter, but the fruit is sweet, says Aristotle. With these meaningful words, I am honored to extend a heartfelt invitation to Dr. T. Kannayan, our esteemed Secretary of PSG College of Arts and Science, to deliver the felicitation address.
Good morning, everyone. Dr. J. Bhuvaneshwaran sir, PSG PSGCAS, Dr. T.M. Subbarao, Principal, PSG IMSR, Dr. Suresh Damodra, and his team of doctors and scholars from USA, and all our faculty and faculty from sister concerns. I want to thank on the behalf of the management to organize such a wonderful conference today. All credit goes to our principal, Dr. Brinda Madam. He was working more than a month continuously to frame this wonderful event. Tirelessly, as he did a lot of work in this field. I congratulate her on behalf of the management to bring with this very useful, demanding field to discuss and to motivate research in this field. Actually, when I was doing my PhD research, I did how to increase golden period of a person gets heart attack now, how to increase the golden period. That is by putting two conducting plates, front side and back side in our T-shirt, inbuilt, that is conducting material, woven T-shirt. You can continuously monitor the inductance of our lungs. When lungs gets water inside, water accumulate inside, the inductance suddenly will vary. By that, we can, you can start your stop clock, golden period stop clock immediately. You will get more elongated time for you to get treatment. That is a small, interesting thing we did. After that, we could not continue because of other workload. I could not do. A very, very interesting field. I wish this program every success. All these research scholars and working professors, doctors, it will be very, very useful to you. Please use this occasion to gain knowledge. Wish you all the best. Thank you very much for this opportunity.
Thank you, sir, for your inspiring words and unwavering dedication. Your leadership shines as a beacon of excellence for all of us. In the words of William Butler, education is not merely about imparting knowledge, it's about igniting a flame within each learner. With these profound words, it's my pleasure to extend a warm invitation to Dr. A. Anguraj, respected Vice Principal of PSG College of Arts and Science, to share his insights with us.
Respected Secretary Dr. T. Kannayan, Dr. T. M. Subbarao, Principal, PSG IMSR, Dr. J. Bhuvaneshwaran, Director, PSG Super Speciality Hospital, Dr. Suresh P. Damodara, President, American Heart Association, Dr. Saktivel Sadayappan, and other doctors in the field of cardiovascular science, heads of the department from various PH institutions, control sections, TQM, and other heads of the department of our college, faculty members, and students, I think all from life sciences and PhD medical sciences. Really, it is a memorable and wonderful day for our college to bring almost 12 scientists, doctors, those who are doing their research, internationally renowned researchers doing their research in cardiovascular science. So such type of programs will be conducted only the medical universities and medical colleges. So we are conducting means really we must happy to celebrate this event. First of all, I thank our managing trustee Sri L. Gopalakrishnan for his generous funding support to conducting this event. As our secretary said, Dr. Brinda, our principal, is taking lot of efforts to organize this event, inch by inch, plan continuously, but due to some government urgent meeting, Madam could not attend this meeting. So really we are missing our principal, Dr. Brinda Madam. And the main initiator is Dr. K.M. Saktivel from our biochemistry department, and his mentor, Dr. Saktivel Sadayappan, Professor of Medicine, Executive Director, Center for Cardiovascular Research. Unless otherwise, Dr. Saktivel Sadayappan, this type of event is not possible. So I thank on behalf of our college, Dr. Saktivel Sadayappan, to bring all the world-renowned scientists from cardiovascular scientists to bring here. Thank you very much, sir. Hope this meeting will be a very, very useful for all life science students. You can learn a lot of things regarding the cardiovascular science. Not only life science students, definitely their talk will be useful for the layman's ignorance about the heart and the cardiovascular, because lot of rumors are going now. After COVID, majority of them died due to cardiac arrest. I hope the experts from all over the world will tell about this. Definitely we will be clear about this idea, whether it is true or wrong. Okay? So I thank the management and the Saktivel Sadayappan and biochemistry department for organizing such a wonderful event. Thank you one and all. Good evening.
Thank you, sir, for your insightful words and profound guidance. We believe in the concept Atiti Devo Bhava, and keeping this in mind, we take this opportunity to honor and felicitate our guests here. With great pleasure and honor, we invite Dr. J. Bhuvaneshwaran, Director of PSG Super Speciality Hospitals and PSG Institute of Medical Sciences and Research, to honor Dr. Suresh P. Damodara, President of the American Heart Association Midwest, Florence Wormald Heart and Vascular Institute, Kentucky, USA. Next, we invite Dr. Hussain Ardahelli, Professor of Medicine, Cardiology and Pharmacology, and Director of the Center for Molecular Cardiology at Northwestern University, USA, to accept a memento as a gesture of honor and appreciation from our Director, PSG Super Speciality Hospitals, Dr. J. Bhuneshwaran. Now we request Dr. J. Bhuneshwaran to honor Dr. Timothy McKinsey, Professor from the University of Colorado, Anschutz Medical Campus, United States of America.
Thank you, dignitaries. A heart that gives, gathers. With this beautiful sentiment in mind, symbolizing the generosity of spirit, I kindly request our esteemed Secretary, Dr. T. Kannayan, to do the honors to our esteemed guests. I kindly invite Dr. Shaktivel Sadayappan, Professor of Medicine and Executive Director from the Center of Cardiovascular Research at the University of Cincinnati, USA, to receive the honors. I'm delighted to invite Dr. Jonathan Kirk, Associate Professor, Vice Chair at Loyola University, Chicago Stritch School of Medicine, USA, to receive the honors. We request our respected Secretary to do the honors. We request our Secretary to honor Dr. Rajashekaran, Associate Professor of Pathology and Medicine at the University of Alabama, Birmingham University, USA.
Thank you, dignitaries, for doing and receiving the honors. In every heart, there is an echo of respect. With deep respect and gratitude, we request Dr. T.M. Subbarao, Principal of PSG Institute of Medical Sciences and Research, to honor Dr. Hind Lal, Associate Professor of Medicine, Division of Cardiovascular Disease, University of Alabama, Birmingham, USA. Next, we call upon Dr. T.M. Subbarao to honor Dr. Shyam Bansal, Associate Professor and Vice Chair at the Heart and Vascular Institute, Pennsylvania State University, United States of America. Now, we request Dr. T.M. Subbarao to honor Professor Dr. Sachin V. Menon, Consultant Regional Director of the American Heart Association, Thrissur, Kerala.
Thank you, sirs. In the heart of every great achievement lies the spirit of collaboration. As we celebrate the spirit of innovation in cardiovascular research, it's with great honor that we invite Dr. Sudha Ramalingam, Director of Research and Innovation at the Center for Molecular Medicine and Therapeutics, PSG Institute of Medical Sciences and Research, to bestow honors upon two remarkable experts. We kindly invite Dr. Pilar Alcaide, Associate Professor at Tufts University School of Medicine, USA. Thank you, ma'am. We kindly invite Dr. Sudha Ramalingam to honor Dr. Satyamangala Nagaprasad, Professor at Cleveland Clinic, USA.
Thank you, dignitaries. In the journey towards better health, every contribution is invaluable. As we continue our journey towards advancing cardiovascular health, it is with great honor that we invite our Vice Principal, Dr. A. Angaraj, to extend honor to Professor Dr. Vishwas Sade, Quality and Certification Consultant at the American Heart Association, Mumbai. Next, we request Mr. Sriman Ashok Kumar, Consultant at the American Heart Association, Kottayam, Kerala, to accept the honors from our respected Vice Principal.
Thank you, sirs. Let us extend our sincere gratitude to these exceptional individuals for their unwavering dedication and outstanding contribution to cardiovascular health and medicine. Thank you, dignitaries, for doing and receiving the honors. An inaugural address sets the tone, igniting the flames of curiosity and paving the way for the journey ahead. It's my privilege to invite Dr. T.M. Subbarao, Principal of PSG Institute of Medical Sciences and Research, to deliver the inaugural address.
Respected Chief Guest of the occasion, Dr. Suresh P. Damodara, invited speakers, esteemed dignitaries, distinguished guests, faculty members, scholars, and students. It is with immense pleasure and pride that I extend a warm welcome to all of you to the International Symposium on Cardiovascular Sciences, organized jointly by the Colleges of Arts and Science of PSG and the Institute of Medical Science and Research of PSG, in collaboration with the University of Cincinnati College of Medicine Center for Cardiovascular Research, USA, and the American Heart Association. Today marks a significant milestone as we gather here to delve into the depths of cardiovascular sciences, a field that holds paramount importance in medical science and healthcare. Our collaboration with renowned experts from the United States of America underscores our commitment to fostering global partnerships in the pursuit of knowledge and excellence. I extend my heartfelt gratitude to the distinguished speakers from the United States who have graciously consented to share their invaluable insights and experiences with us. Their expertise and contributions to cardiovascular research are unparalleled, and we are privileged to have them as our resource persons for today's symposium. Symposia serve as platforms for intellectual exchange where the ideas are cultivated and knowledge is disseminated. For our young students, postgraduates, and research scholars, this symposium will present a unique opportunity to gain first-hand exposure to cutting-edge research, innovative methodologies, and emerging trends in cardiovascular sciences. As we embark on this journey of exploration and discovery, let's not underestimate the profound impact that symposia like this can have on the academic and professional endeavors. Beyond the presentations and discussions, it is the exchange of ideas, the forging of collaborations, and the cultivation of a shared vision that genuinely enriches the academic community. To the faculty members of all the basic sciences departments, I urge you to seize this opportunity to engage with our esteemed speakers, leverage their expertise, and inspire our students to pursue excellence in their academic and research endeavors. In conclusion, let us embrace this symposia as a growth, innovation, and transformation catalyst. May the insights gained and the connections forged during these deliberations propel us towards new frontiers of knowledge and understanding the cardiovascular sciences. Thank you once again to our esteemed speakers, collaborators, and participants for your unwavering commitment to advancing scientific inquiry and scholarship. Together, let us chart a course towards a healthier, more vibrant future for our future generations. Thank you once again.
Thank you, sir, for setting the tone for a journey towards advancing cardiovascular health. Drawing inspiration from the words, "Great leaders inspire greatness in others," it is with immense honor that we extend an invitation to Dr. Suresh P. Damodara, President of the American Heart Association Midwest, Florence Warmold Heart and Vascular Institute, Kentucky, USA, to deliver the chief guest address.
Thank you, everyone, for inviting me. And for a minute, I wanted to say something in Tamil because my wife told me I cannot do that. So, ellarkum vanakkam. It gives me immense honor and pleasure to, one, be here, two, tell a story today for all of you to know that every one of the students that you could be here or you could be one of us sitting on the stage. So the first part is just to say where I came from, my journey, and the second part is to describe what the American Heart Association is, what the goal of the American Heart Association is, and how we could collaborate together and where this journey can take us in the coming years. And it's not just in India, but it's all over the world in the 13 countries that we currently are in. So I grew up in Chennai. I went to school in Chennai. I went to Madras Medical College. My mother was a zoologist, was a principal of a college in Madras. After finishing my medical school, I did my MD and then went to the US and spent 25, 30 years. I'm a practicing interventional cardiologist, taking care of a lot of patients. About 10 years ago, I started getting involved with the American Heart Association in a very significant way, because the practice of medicine was one thing, but trying to understand how can this be translated to help a lot more people. So if somebody comes in with a heart attack today, I can take care of one patient, open their artery, make them live hopefully better and a longer life. But if we can translate this to a lot of people, to a lot more part of the community, how could we do that? And that's where the AHA vision of community involvement comes into the core. So in the basic concept, the American Heart Association was started exactly 100 years ago in 1824. So this is the 100th year of the AHA. So the AHA, if I were to call it, is divided into three big parts. One is basic science and research, which is why we are here, and all the professors and esteemed guests and all of you students actually participate in research and provide various groundbreaking research. The first stents, the first pacemakers, the first bypass surgery. 20 years ago, I got my first grant from the American Heart Association to work on 2 genes in heart failure. So a lot of basic science is funded by the AHA. The second part of it is the clinical care that we do, and it's anything that you do with the field of cardiovascular disease and stroke. The American Heart Association is also the American Stroke Association. So cardiovascular disease and vascular disease, every part of it, the AHA is involved. And then the latest part, and over the last 25 plus years, is the community engagement. The whole concept of emergency services, CPR, cardiopulmonary resuscitation. So later today, I'll be talking about CPR and the impact that it can have in India and in the rest of the world. And the final part of it, which is why I was in Bombay day before yesterday, is we are embarking on creating a consortium of hospitals throughout India to do quality programs. So i.e., when somebody comes in with a heart attack to, let's say, my hospital system, there is a process, protocol, methodology that follow before the patient even comes to the doctor, right? So that's the processes and protocols. Can we bring that to the rest of the world by means of accreditation and certification programs? So right now we have 4 health systems, the MGM health system in Navi Mumbai, MS Ramaya in Bangalore, Aster Medical Group in Kerala, and the Apollo Hospital Group in Hyderabad as the 4 pilot hospitals. And the idea is to create this system of care or methodology so that a lot of patients who come, it doesn't matter who the cardiologist or who the doctor should be, how can we do this again and again to improve the care of everybody who comes to the hospital, irrespective of who they are. So that's the premise of starting these quality and certification programs that we intend to embark on in 2024, being the 100th year of the AHA. And then slowly, I'm sure PSG would also be involved and interested in doing something like that in the near future. So the idea is to come and help the institutions, and I want to make this very clear. This is not the American Heart Association. This should be the PSG Heart Association, or the PSG method of how you can do it. We just provide some of the best practices that are present in the rest of the world. The physicians in India are amazing. They do excellent work. It's just that some of the things that we do in the US is slightly different than what we do. The idea is to create an Indian equivalent for that. So how we come up with that, and how you could really look at the data across all the 4 health systems first, and maybe that'll become 40 or 400 over a period of time. The data would be housed in India. The data would be de-identified, so nobody will know whose patient it is and who the doctor is. Then you can compare various things of various treatments that we can do in India that will be different. நீங்க சொன்னீங்க முன்னாடி இந்தியால வந்து வேற மாதிரி இருக்கும்னு. So it's very true. 1 in 3 patients in India actually will die from cardiovascular disease. Don't want to scare all of you, but 1 in 3 of you, just think and see, will have heart disease at some point in your life. That's the honest truth. More importantly, if I take a blood pressure now and check individual blood pressures of everybody in this room, 1 in 3 of you would probably be borderline hypertensive, meaning your blood pressure would be higher. 1 in 3 of you would have a slightly higher sugar in your blood that you do not know about it. So cardiovascular disease is extremely common. The idea is, how can you prevent it? How can you identify it? How can you treat it? I don't think you can completely prevent it, but at least knowing about it and teaching everybody. You don't need to be a doctor to learn about it. You could be anybody. But the idea is, as many people, if we can spread that, you can take care of yourself better. And the 2 key points that I want to mention is sleep and stress. When I come to India now over the last 30 years, sleep, people don't sleep much, and the amount of stress, everybody wants to be like somebody else, everybody wants to go to some other school, there's somebody richer than somebody, there's somebody more beautiful than somebody else, there's somebody more smarter than somebody else. You have to be yourself. The more you become yourself, know thyself is what people say. If I can tell one thing to the students, that's what I would say is, I always used to be in the back bench. I don't think I listened to many lectures in school. I was never the top of my class, either in high school or in medical school, but somewhere along the way, I decided that I had to outwork everybody else over a period of time. It's not, life is not a sprint, it's a marathon. So the longer, you may be in the middle of your class, you probably will outshine everybody in the first few because you'll work harder. So the idea is, I want everyone to work as much as possible, work as to your own best self. Don't look at somebody else. There's always somebody who's going to be better. You could be the other person too. With that, I want to say profound thanks to all the invitees. I want to talk a word about Sakti before he comes up and says something about me. எனக்கு வந்து சக்திவேல் வந்து 20 வருஷமா தெரியுங்க. Saktivel is an amazing human being. அவர் இங்கே தான் இருந்தாரு. He is an amazing scientist, basic scientist. I may take care of patients. He's done a lot of basic work in terms of over the last 20 years. I'm not here today if not for Sakti. He invited me and he told me, DP, நீங்க வரணுங்க, நீங்க வந்தா ரொம்ப நல்லா இருக்கும். People வந்து உங்களை கேட்டு, they'll be, especially the students will be very excited that they could do this also for themselves. So I want to first thank Sakti, and it was sort of his brainchild to do this. So with that, thank you, Mikka Nandri, thank you.
Thank you, sir, for your insightful and inspiring address. Your words have shed light on the importance of cardiovascular health and has left a lasting impression on all of us. In the realm of knowledge, the keynote speaker is the guiding light illuminating the path ahead. As we embark on this journey of discovery and enlightenment, let us welcome our renowned speaker, Dr. Shaktivel Sadayappan, Professor of Medicine and Executive Director of the Center for Cardiovascular Research at the University of Cincinnati, USA.
Respected Secretary Dr. Ramesh, the Principal Ma'am, Dr. Brinda, Dr. Bhuvaneswaran, Dr. Sudha Ramalingam, Dr. Anguraj, Dr. Kannan, Dr. Subbarao, and the PSG college, you guys, the students. I want to thank all of you, first of all, before I go into the next one, and really, humble and honored to be here. And I want to thank all of you for putting together so much time and effort to organize this, our first symposium, right here in my homeland. So thank you so much. Secondly, I also want to thank my partner in crime, Dr. Saktivel, so another Saktivel, and his colleagues. Again, I want to recall Dr. Ramesh, Dr. Mohan Das. I want to thank them again for all their support. The last, I would say last 5 months, every day hundreds of emails, hundreds of WhatsApp messages, how to organize this symposium, what are the things we have to do better, symposium. So there was so much time and effort. So I want to recognize and thank them again. Also, I want to thank the American Heart Association, particularly Dr. DP Suresh. He already called out my name. Suresh, நீங்க வந்தது தான் இதுல வந்து பெரிய ஒரு வெற்றி இதுல, சரியா? So he is my close friend and also a wonderful colleague in Cincinnati, and we are family friends. So I want to thank him, and also the American Heart Association, Heart and Stroke Foundation of India. Colleagues are here, and I want to thank them again because of their constant time and support. Again, we communicated so many times to put together the CPR training. You will see this afternoon. So that's another big plus for the symposium. So I thank them. Lastly, I want to thank my wonderful colleagues all the way coming from the States. They trusted me to come to India. You know how, there is an image on how India look like or based on what we. So I wanted to break that, and I want to bring more Americans or US, to India and show how we are, who we are. So I want to thank them again, So I have 3 more minutes. So what I'm going to do the next 3 minutes. So நோய் முதல் நாடி அது தணிக்கும் வாய் நாடி வாய்ப்பச் செயல் அப்படின்னா என்னன்னு தெரியுமா? ஒரு நோயை நீங்கள் கண்டுபிடிச்சு அதுக்கு சரியான முறையான ஒரு ட்ரீட்மெண்ட் எடுத்து அதை கம்ப்ளீட்டாக ரிமூவ் பண்ணணும், அதை எராடிகேட் பண்ணணும் அப்படிங்கிறதான் அதனுடைய குரல், அதனுடைய அர்த்தம். திருக்குறளில் இது திருவள்ளுவர் அந்த காலத்திலே சொல்லி வச்சுருக்காரு இது நமக்கு. ஸோ அதை சொல்லி I wanted to start with my, the little speech. We are here for 2 reasons. One is we want to promote cardiovascular health among the youth, you guys, and Indians. And secondly, we are here to really support or motivate again the younger generation, you all, to start and to research in cardiovascular. So these are the 2 main goals for us today for this particular symposium. And why we have to do this? I mean, heart disease is the #1 killer worldwide. As Dr. Suresh and Dr. Bhuvaneswaran indicated, we have higher risk than any other populations. We have almost 4 to 5 times higher risk. Younger people within 30s or within 40s, they have a heart attack. We don't know. There are a lot of reasons we could name, but we have to start promoting cardiovascular health, how to take care of our heart. That's the #1. Number 2, researchers. We need more researchers. We need more clinicians in cardiovascular research to treat this deadly disease. So you will see all the talks today. We have excellent speakers. Please come forward, ask questions. So I'm going to be the first speaker, and I'm going to pull everyone to ask us questions. I'm sure we have a mic to go around, so then we can have a lot of discussions. So with that, I want to thank you all and have a wonderful day. Thank you.
Thank you, sir, for gracing the occasion and creating an awareness among the young population on cardiovascular health. In the pages of collaboration, we find the blueprint for progress. Let us remember this in the momentous occasion as we gather to release a compendium, a testament to the collective efforts and dedication towards advancing cardiovascular health. It's my honor to invite Dr. Suresh P. Damodara, President of the American Heart Association Midwest Florence Wormold Heart and Vascular Institute, Kentucky, USA, to join us in this significant moment and release the compendium. Now, may I kindly request Dr. T. Kannayan, Secretary of PSG College of Arts and Science, to receive the compendium on behalf of our institution.
Thank you, dignitaries. Gratitude is the fairest blossom which springs from the soul. It's my pleasure to invite Dr. L. Uttra, Associate Professor and Head of the Department of Nutrition and Dietetics of PSG College of Arts and Science, to propose the vote of thanks.
Dignitaries on the dais, resource persons, heads of departments, faculty members, delegates and students, good morning. We express our deep gratitude to the chief guest, Dr. Suresh P. Damodara, President, American Heart Association, Executive Medical Director, Midwest Florence Vermald Heart and Vascular Institute, Kentucky, USA, for the excellent summation on personal journey and goals of American Association. Today, we had an opportunity to hear from you. Thank you, sir. We are indebted to thank our secretary, Dr. Kannayan, for the unstinted support offered towards organizing the symposium. Conducting the symposium would not have been possible without the zealous efforts by our principal, Dr. D. Brinda, and we are thankful to Madam in absentia. We thank our Vice Principal, Dr. Anguraj, for the ardent support given. Our profound thanks to Dr. Shaktivel Sadayappan, Executive Director, Center for Cardiovascular Research, University of Cincinnati, USA, for delivering the keynote address. We would like to acknowledge with gratitude the enormous support rendered by Dr. Subbarao, Principal, PSG IMSR, for organizing the symposium. Our appreciation and sincere thanks to Dr. Bhuvaneshwaran, Director, PSG Super Speciality Hospitals, PSG IMSR, for the insight shared regarding the significance of the symposium. We are thankful to Dr. Sudha Ramalingam, Director, Center for Molecular Medicine and Therapeutics, PSG IMSR, for extending guidance to conduct the symposium. Our heartfelt gratitude are due to all eminent resource persons across varied institutions of USA and also representatives of American Heart Association. We especially thank delegates from other institutions, heads of departments, faculty members, and students from our own institution. Special recognition to the sponsors of the symposium, Kalishwari Refineries Chennai, Salem Microbes Limited, High Media India, Kannan Coffee, Sistron Biological Laboratories. We thank them wholeheartedly. Our thanks to technical team, maintenance department, for helping us with the necessary arrangements for the symposium. Thank you.
Thank you, Madam. Ladies and gentlemen, as we prepare to conclude our morning session, we invite you to join us for a refreshing tea break. Kindly proceed to the designated area for refreshments and networking opportunities. We kindly request you to promptly return at 11:20 a.m. for the commencement of our highly anticipated technical sessions. Thank you for your participation and cooperation.
Sadayapan from University of Cincinnati. I want to echo what Dr. Suresh said earlier today. Sakti is a wonderful human being, and I'm very lucky to have him as a friend and colleague. And today he's going to talk about heart disease leading cause in Indians. Is it genetics or the jalebi? Now, I've had the jalebi, so Sakti, you have to promise us the answer is not jalebi, it's genetics. So hopefully that will be the answer. Thank you.
Good morning again. How is everyone doing? Did you get your coffee? Yes. Are you ready for the talk? Okay, I'm going to ask you a lot of questions, so pay attention to my talk, okay? So, again, I want to start thanking all my support, all our support. You can see all the names here. Really put together this wonderful symposium. So thanks to them. Yes, please. Also, I want to give a very special thanks to my colleagues. Obviously, after this talk, I have to go back to US and then I have to work with them. So I have to thank them again. Thank you so much again for coming all the way and spending time with us. So these are my disclosures. I have a lot of interaction with companies and etc. So, but nothing to do with my today's talk. So very simple disclosures. So I'm going to start with very basic about what is the heart. You all know, right? You have one heart, right? Not two, only one. It's so important to know what is that means and how you take care of that one heart. So when you go back to the history, heart always like campus. இவன் வந்து நல்ல heart இருக்கு இவனுக்கு. ஏன் வந்து we are always say heart, you know, so we start that, but it goes back to the old history. In ancient Greek, they thought, they proposed in our soul is in the heart. Heartla dhaan uyire irukku appdin. Then it's started as a symbol of love, and then it's started as a symbol of religion, and then this British, they put this Valentine's with a love symbol. It's not stopped there yet, so now we know. It's even worse. You know, we use this all the time to express our love. So, it beats 72 times per minute, almost 100,000 times per day. It's a non-stop engine in your body. It pumps nearly 5 to 7 liters of blood in 1 minute. Just think of a motor in your backyard. And then 7,600 liters per day. You can imagine how much we are doing in our body. So this is a simple video on how a heart attack comes through. I think Dr. Bhuvaneswaran, Dr. D.P. Suresh, they indicated coronary artery disease. It's a heart attack. So when we have an occlusion here, there is no blood supply to the part of the heart. And end up in damaging the heart. The sooner you go to the hospital, you get a better treatment. Sometimes we assume just a nenji erichal. Then you go next day morning, it's too late. So someone in your family, your neighbors, your friends, if anybody show any signs of heart attack, immediately they have to go to the hospital. Again, heart disease, heart failure is the #1 killer worldwide. You can combine all type of cancers, still heart disease is the #1. If you are diagnosed with the heart disease, there is a chance, 24%, the patient, they die within a year, and then 50% they die within 5 years. So again, it's so important to know where or how this disease start and develop and the current status. So what is Indian phenotype? So I have a lot of questions now for you guys. Number one, India is the most now the populous country. We have almost 1.4 billion people. Very crowded everywhere, wherever you go, traffic, everything is crowded. The question is obesity considered as a sign of wealth and good living? ஸ்டேட்ஸ்லேருந்து நான் எப்போலாம் ஊருக்கு வரும்போது the first question ask, சக்திவேலு ஏன் இப்படி மெலிஞ்சு போய் கிடக்குற, சாப்பிட மாட்டியா? So again they think that if you are lean, if you are thin, they assume that you are not wealth. நல்ல பெரிய belly, கொஞ்சம் வெயிட்டா இருந்தா then you are a wealthy guy or good guy or healthy guy. But that is not true, right? The second question, are Indians generally not overweight? Have you seen anybody overweight? We always say Indians are thin and lean. But again, it's not true. You can see a lot of obese in our country, particularly after exposing to Western diet. KFC, how many of you go to KFCs? See, already there are a number of people. I see a lot of in the back row. So remember this. Is a vegetarian diet considered healthier? Yes or no? No. We eat a lot of, vegetables or not vegetables, carb-rich diet. They are not healthier again. Look at all these sweets. How much calories? So much. If you take one jalebi, it's almost like 150 calories. If you eat 5 of them, it's like enough for a day. So much calories. If you are crossing the age 30, 40, 50, if you consume more, then it's going to stay in your body. Last question, are Indian women at a lower risk for health conditions? No. Most of the cases, they don't know, they don't have the awareness. They work very hard. They support the family. They support their kids, and they don't have a time to take care of themselves. We need to give them the awareness. Again, this is an opportunity. So, as I said before, we Indians have higher risk for heart disease than any other population. There are a lot of reasons for that. So, number one, I would start with lifestyle choices. We eat very high carbohydrate diets, low fibers. For example, when you go for any festivals or temple functions, you can see all rice, big banana leaf, a lot of rice, alla kuli parichu, சாம்பாரை ஊற்றி ஒரு கலக்கி we eat so much. பருப்பு, அப்புறம் ரசம், அப்புறம் தயிர், அப்புறம் பாயாசம், it goes on. So much carb we eat. It's not good. We also now exposed to Western diet. Pizzas, burgers, fries, KFC. Most importantly, we don't do exercise. That's another thing. We have a lot of work now, just sitting at computer or somewhere at the desk, and we are not doing any exercise. That's another risk. So what are the risk factors we have? We have hypertension, diabetes, and then also higher cholesterol. These are part of the secondary risk factors for developing cardiovascular diseases. So what is hypertension means? How many of you have measured your blood pressure? Anybody? Can you tell us what is the normal blood pressure means? 120/80. That's the key number. You have to know, and you have to tell your parents, you have to tell everyone in your circle. How often you should measure? Very like every month or every 6 months, every year, at least you should check your blood pressure. So again, there is a guideline. Normal blood pressure are stage 1 and stage 2. Indians have a lot of hypertension patients. Then the other risk factor is the belly fat. This is a very kind of normal, very low risk. The visceral deep belly, this is the one is very risk one, which you will see in this picture. They have more fat inside the belly. So that's a very risk for developing heart disease. Again, Indians, we all look thin and lean, but we have more fat here. And then lastly, all genetic predisposition. So you can see a lot of genetic linked heart diseases because of number of reasons again. And we do a lot of cousin marriages. Within our family, within our close relatives, we see a lot of heart disease patients. So now I am coming to the part what I am doing, who I am really, and what I am doing in my research. So my journey started here from southern part of India. The place I come from, Patti, Veeranpatti, Dindigul district. How many of you from Dindigul district? Anybody? There is no one. Okay, there is one person. I see here. Thank you, thank you. Dindigul na put in. Thank you. So the place is very nice. My parents are farmers. We grown up in the farmland. They never went to school. My parents never went to school, but they promoted me to study, just to get my free lunch for going to high school or school times. This is the time, education started promotion. So I went to Madurai Kamaraj University for my PhD. I went to Germany for my second PhD as well as postdoctoral training. Then Cincinnati, Chicago, Cincinnati again. Started traveling all over the world just to study cardiovascular diseases. I focus on studying the disease called hypertrophic cardiomyopathy. It's a genetic heart disease. You can see when you have a genetic heart disease with the hypertrophic cardiomyopathy, the heart is enlarged. The wall chamber is thick. The chamber is smaller. A lot of athletes, they are very aggressive athletes. We know they passed on the field just having this disease called hypertrophic cardiomyopathy. An example, our former minister, Murasoli Maran, he was diagnosed with hypertrophic cardiomyopathy. Again, just recently we have a drug to treat hypertrophic cardiomyopathy, but in the last years there was no drug. It's all surgery protocols. So in India, we have number of places already they are doing research on this disease, hypertrophic cardiomyopathy. Again, screening for genetic defects in your gene. It's a starting point. This is the family I worked on. I identified a genetic variant in one of the muscle gene, and it's directly linked to develop the disease hypertrophic cardiomyopathy. You can see this particular subject came to the hospital. We screened, and then we extended the study to collect samples from all over the family, and then we identified the cause for developing this particular disease. We also do stress exercise test for patients. We bring the subject to the hospital, we make them to do exercise, and then we do electrocardiogram to look for whether they have a heart disease or not. So this is part of our study Even though I am a basic researcher, but I do clinical research, identifying all the risk factors and how they are related to heart disease. So we develop animal models for the same, whatever we have in human, and then see whether the gene mutation or the genetic variant is responsible for developing heart disease. So using genetic modifications. So here is the heart of a mouse, a normal heart, and here is the mutant heart, almost like in humans what we see. In the mouse heart, within 3 months, we see a hypertrophic phenotype. Using this model, we can understand the mechanism, we can start developing treatment, all the basic molecular biology and therapeutic strategy we can come on. Our studies were covered on CNN. So again, it's South Asian, it's Indian population. It's so important because of the population we have and the number of heart patients in this country we have. So the question is, okay, I am born with a genetic defect. If I have a unique or different lifestyle, like eating a lot of jalebis every day, or drinking a lot of sugary coffee or tea, or eating so much carb, is that going to affect my the disease outcome? So the ongoing study using the hypertrophic cardiomyopathy in a mouse model, we are challenging those mice to the diet, including jalebis, not exactly jalebis, but sugar treatment or high-fat treatment, and then see the impact. Our working hypothesis is that if you expose the hypertrophic cardiomyopathy or condition to diabetic or hypertension, you end up in developing heart failure. Severe disease, then already you have it. So a combination of multiple risk factors can aggravate the disease development. So we have to, as an Indians, we have to study, we have to focus on understanding the cause for the heart disease, and then start early diagnosis, and then do the treatment. Again, prevention is better than the treatment. Have the awareness on So my last 4 slides are, okay, what we have to do in order to prevent or improve. Number 1, moderate and regular exercise. It's very, very important. You do exercise, but you have to do on a regular basis. That's very important. Number 2, a healthy diet is really critical. As I said before, not so much rice, less vegetables or less protein. You have to have a moderate, having enough proteins in your diet. Also, it's very, very important to have an uninterrupted sleep. At least 6 to 8 hours, it's really must. Lack of sleep also cause metabolic diseases. They related to heart disease. And lastly, excellent mental health. This is also very important. Why we have to stress out for something that we cannot control? So you have to have some calm and then quiet or like peace of mind all the time. Be happy, thankful for what you have rather than stress out or worry about the neighbors or worry about your classmate or how to get more marks, etc., etc. So have an excellent mental health. So with that, I want to acknowledge my team in Cincinnati. I have graduate students, I have postdoctoral fellows, I have fellows in my lab. They get trained. You can follow me on LinkedIn, Twitter, Facebook. This is my website. These are all my mentors and collaborators. This is my current lab in Cincinnati. We not only do research, but also do a lot of activities. So again, we have to celebrate what we do. It's not like 24/7, you work. So if you come to Cincinnati in summer, this is May, it's a beautiful green, but if you come in December, just opposite. Very cold, so much snow. Sometimes we get a lot of visitors in our front yard, When I come out of the house, I see these deers. It's very nice. You feel like you live in a natural way. And again, Cincinnati, it's a big city. We have 300,000 people live in a city. We have a big river. This is called Ohio River. We have a soccer team. We have a football team. We have a wonderful skyline chili. It's for Cincinnati's specific meal. So with that, I want to thank you all and happy to take any questions you have.
All right, thank you, Sakti. That was an excellent presentation. So I encourage students, please, I think there is a microphone somewhere. If you have any questions, please raise your hand and we will give you the microphone to ask questions.
Can someone give the mic?
We have an extra one up here.
Here. How much time we have? 5 minutes?
10 minutes. 10
5
minutes.
Yeah. Students, be ready for questions, okay? I'm going to give you some prize if you ask a good question.
Sir, India is called as the diabetic capital of the world, sir. Is it diabetes the most important risk factor for Indians with heart disease?
It is one of the most risk factors.
Which is the most important risk, sir?
Yes, it is the most important risk, yes. It is. So again, if you have a diabetic, start early. Moderate diet, moderate exercise, keep looking after your blood, glucose and insulin levels. It's all important.
Respected sir, diastolic heart failure.
Can you identify your name, please?
Dr. Jagdishwari from PSGCAS, sir, physiologist. Diastolic heart failure in relation to hypertrophic obstructive cardiomyopathy.
Correct.
More than systolic failure.
Correct, yes. Oh, so the question is it the obstructive is more than, yeah. So most of the hypertrophic cardiomyopathy, the myosin heavy chain, the motor protein is hyperactive. When it is hyperactive, the muscle gets thicker and then the obstruction forms. And so now the last 1 year we have a drug called mavacamten to specifically treat the obstructive hypertrophic cardiomyopathy.
Sir, kindly repeat the drug name, sir.
Mavacamten.
Yes.
Yeah.
Thank you.
Good morning, sir. I'm Dr. Y. Tangam from JKN College. Sir, this hypermyocardiopathy, is it affects the coronary arteries?
Not directly, but I think there are some evidences that once you go to a severe level, there is a possibility.
Okay, sir.
Yeah.
Thank you, sir.
Thank you. Questions from the students?
Yeah, let me finish with the faculty as such. Okay. Thank you, Shaktivel, for your wonderful eye-opener type of your presentation for the youngsters who have assembled here. I have a small question for you because just a week back, there was an incident in our department where one of our staff's father, who's said to be 100% perfect in all the type of your parameters, okay? No BP, no sugar, okay, no genetic type of your inheritance that he has got it, and all the biochemical parameters are perfect, and he's a good agrarian who works regularly in the case of your farm as such. But he has gotten cardiac arrest. What might be the other risk factors that is associated with that, and why such type of things are happening? That is my first question. And my second question to you is that, see, when you're saying that to maintain the perfect health, the sleep, as well as the type of your mild exercise that you wanted to do it, some people maintain it very perfectly, but during the sleep they get a cardiac arrest. And during the walking or do their jogging, that they get a cardiac arrest. What might be the reasons for this?
So the first one, again, you can look like completely normal, but you don't know the cardiac function. Most of our people, we do not do echocardiogram. or even electrocardiogram. These are like non-invasive, very cheap, but we don't do that, because it's normally not recommended. So in those cases, they may have some genetic defect, which is not, kind of outcome as an outcome. So they call sudden cardiac death versus heart attack. Heart attack is a myocardial infarction. It comes because of the LAD ligation or blockage. But sudden cardiac death is just the lack of the contraction or stop the electrical contents in the heart. So these are two different. So again, we do not know. Maybe they have genetic factors. They already have some symptoms, but we don't know that. So that's one. I think the second one, why people die in the morning, I think I would refer to Dr. Hussain. He's our cardiologist. In his talk probably, or he can answer the question.
I think the idea is that in the morning, the stress on the body is higher. The cholinergic activation of the body is higher. So that's what is believed to be the cause. So if that's correct or not, we don't know, but that's basically, that has been proposed. Sakti, can I ask you a question if there are no other questions?
One second, yeah. I want to make sure the students, question from the students' backside. There is one all the way in. There are two.
Sir, what may be the potential cause for heart muscle weakness, sir?
Heart muscle weakness, again, many reasons, genetic variants or injury or viral infections. So there are so many reasons can lead to muscle damage or muscle weakness.
Okay, thank you, sir.
You're welcome. Two more. Yes. Okay.
Sir, good morning, sir. I'm Devirashni. I'm a student from microbiology department. Is there any disease related to microbial attack of heart, sir?
I think all we know so far, the viral myocarditis, viral mediated heart disease. I think some of the recent work can related to microbe, what diet or how we exposed to various microbes. They also can lead to develop some heart disease, but they are still under studies.
Is there any disease, have you already found, sir?
Not in my research. I focus on genetic studies, yeah.
Okay, sir. Thank you, sir.
Thank you. There is one here.
Good morning, sir. I am Shobhya from Department of Biochemistry. My question is about the hypercardiac myopathy is due to the inflammation.
Genetic.
It's a genetic cause due to the inflammation. Whether the enzymatic treatment will reduce the inflammation of the heart, will it be a source of remediation for this?
Yeah, so hypertrophic cardiomyopathy mostly on myosin heavy chain, the motor protein. What happens is the genetic defect can lead to increased function, So again, if you run 1 hour per day, you are okay, but if you run 24/7, it's not good for your health, right? Same thing, the myosin heavy chain, when you have a genetic mutation, is very hyper, So that's why you develop this bigger heart to compensate. So early stage, if you know the genetic variant, if you can start the treatment early on, you can prevent developing the disease. But inflammation is a secondary cause related to hypertrophic cardiomyopathy. What enzyme?
So actually, which reduces the inflammation like that. So whether those enzymes can be used?
Yeah, I think so. I think Pilar is going to give a talk. She is an immunologist, so she can answer that question specifically.
Yeah. All right, I think we are going to stop here to move on to the next talk. For the next,
Thank you.
yeah, thank you, Sakti. Excellent talk. Thank you
Thank
so
you.
much. For the next session, my co-chair is going to introduce the speaker. But for the next talks, I recommend that the people who have questions, please come to the front, to the middle row, right behind the camera, and we will have the microphone ready for questions there, so we don't move the microphone throughout the conference room. So.
Thank you, Hussein. It's my pleasure to introduce next speaker for this session, Dr. Pilar Alcaide. She is a full professor now at Tufts University School of Medicine. She is a world-known expert in immunology of heart failure, and her talk today is going to be on the immunology of heart failure, her favorite topic and mine as well.
Is it on? Is this on? Yes, it is. I just need my pointer. Hello, good morning, everyone. Yes, okay. Okay. Okay.
Just to answer.
You want to answer the question? No.
Next session, right? We extend our heartfelt thanks to Professor Saktivel Sadayappan for his enlightening session on busting the common myths about heart attack and cardiovascular health in an interesting way. Thank you, sir. We invite Dr. Victor Arogyadas, Associate Professor and Head of the Department of Biochemistry, to felicitate Professor Sadayappan.
Sorry.
Thank you, sir. Now we are privileged to introduce the renowned speaker for the session 2, Dr. Maria Pilar Alcaide, who is currently the Professor of Immunology and the Director and Assistant Dean in Tufts University's School of Medicine. Dr. Maria has obtained her BS and PhD from Spain and obtained her postdoctoral training from Harvard Medical School. She has been honored with 15+ awards, including the Fulbright Scholar Postdoctoral Fellowship Award, Pathway to Independence Award, Cochrane Early Career Investigator. She is a member of several professional societies and also the mentoring graduate for postdoctoral candidates. Dr. Maria is also the associate editor in the Journal of Molecular and Cellular Cardiology and also the reviewer for several reputed life-size journals. It's an honor to welcome Dr. Maria to share her expertise on the topic, the immunology of heart failure. We kindly request Dr. Shyam Bansal and Dr. Hussein Adehelli to chair and moderate the session.
They introduced me already. Hello, good morning. Can you hear me? Yes? So the microphone is good? All right. I think I'm going to go here. So it is my pleasure to be here. I want to thank the organizers for hosting this amazing event. This is my first time in India. I'm really enjoying meeting all of you, and I look forward to meeting all the students, faculty, and staff that are making this happen. So I am from, I come from here, Tufts University. And Tufts University is in Boston. So this is an aerial view of downtown Boston. There is a very nice park in the middle. And in that circle on the right is where our campus is. And I'm happy to say that our new president of the university is actually Dr. Sunil Kumar from India. We also have a new provost for research, so the director of all the research in all the schools in the university. And his name is Bernard Arunalandan, and he's also from India. So for all the trainees out there and everyone sitting there, there's a lot to do, not only here, where you can do a lot for cardiovascular disease and research in general, but also in the world. So there we go. So I'm going to tell you a little bit about my journey. So I'm currently in Boston, but I am not from there. So I'm actually from if this works. I don't think this works, but. It's not going. Okay. Okay, so I'll do it from here, maybe. Yes. Does that work? No, this is. No, but that's not because I'm pressing. Okay, yes, good. Okay, so I'm actually from Spain, which compared to India, as you can see here, is a very tiny country, but it's very exciting. So if you ever get to have an opportunity, also go. And within Spain, that is very small. No, this is. So within Spain, I'm from there, from Madrid, which is right in the center of the country. And I went to school there. I went to college in the University Autónoma of Madrid. Then, after that, I crossed the Atlantic and I moved to Boston for my postdoctoral studies. And I did my postdoctoral studies at Harvard Medical School over there. And then from there, okay, from there, we will wait 1 second, be patient, and then you will find out the rest of my journey. I think it's better from there. Okay, let's try now. Here, okay. These are like this or like this? No, like this. Okay, so here we go. And yeah, I can advance from here. No, so this is. Okay, good. So maybe from there or from here is better. We'll try. So then from there, I went to Tufts University, which is also in Boston, about 20 minutes away from the Harvard Medical Campus. So that is my journey, but what did I do during my journey other than moving around? So this is still not moving. I don't know what's going on. Now, okay, good. So now it might be a slow motion or, so now this is what I did. So when I was in Madrid, I told you where I'm from. But now this is what I did in terms of science. So in terms of science, at the University Autónoma of Madrid, as a little kid, I was very interested in immunology. And I suffered from an autoimmune disease. And I was always told that the immune system protects us from pathogens. But then I could never understand why, if it protects us from pathogens, why it was hitting me with a disease, right? So I decided to do my PhD in immunology, and I studied how a parasite that is called Trypanosoma cruzi, which is not in India, but is in a lot of parts of South America, how that induces an immune response. And we'll talk a little bit more about that. Then, maybe I can advance it myself, or, okay. So then in my postdoc, I said, well, immune cells are fascinating, they fight pathogens, but how do they travel in the body and go to places? So that's why I decided to study vascular biology, because for those immune cells to travel to the place where they are needed, they need to interact with the vasculature, with all those blood vessels that Sakti showed us before. So that's what I did my postdoc in. And then I decided to start to kind of like close and bring all my expertise to understand how this occurs in the heart and in heart disease for all the reasons that Sakti indicated from. So then once it does, I was an assistant professor, an associate professor, and then recently became a full professor. So previous one? Yes, okay. So college studies in biology and PhD, so what did I learn during those PhD studies, right? So what I learned, yes, please. What I learned, obviously, is that the immune system, it has many cells and many places, and it protects us from pathogens. So you have all the pathogens that are surrounding you, and when our immune system is boosted or strong, we're protected from everything. And when they try to attack us, we have like an army of soldiers that will protect us in different ways. So that, okay, so that army, yes. Can I see if I can advance it myself or not? No. Okay, so you need to advance them for me then, right? So this is not, I'm trying to advance my own slides, but this is not advancing, right? So can you, okay. Or how do I do it if, what do you recommend to do? I mean,
can we get the laptop here? So she has,
yes.
Can we get the laptop? Yeah, so she can.
Yes, because this is not advancing. So after these technical issues, we will. That protect us as well, or we have there other lymphocytes that basically will remember what they've seen and will act in the tissues, right? So again, they're distributed and ready, and it's all for good. We have them in the thymus, in the liver, in the lymph nodes, in the gut. The gut is a big reservoir for immune cells. So all those diets that we heard in the previous talk from the previous speaker, how diet is so important, in part is very important because alterations in your diet can also alter the immune cell reservoir that you have in the intestines. Bone marrow, tonsils, when you get sick, your tonsils get inflamed, everywhere. They're ready and they evolve to heal when there was injury and to kill when there was a pathogen that needed to be killed. So that's all very good, right? So I'll just show you one example, like a classic example of the immune responses when you get a cut, right? So you have your immune system, and then your skin breaks, and what happens there is that you have the rapid response, you have a lot of cytokines, that we'll get to that later, you have immune cells, you have blood vessels, and then you have a tissue that needs to heal. You have also a pathogen there, remember? So far we're talking about pathogen response. So then what happens? Then what happens is that inflammation, either the immune system gets activated, the tissue is healed, and then it resolves, and there's a perfect balance about effector cells that are the ones that heal, and other cells that are the ones that have to suppress that inflammation and get back to resolution. But in many cases, what happens is that the immune system gets dysregulated. And that's what brings us to cardiovascular disease, right? So when it gets dysregulated, then you have a constant influx of cells that keep going to either try to fight for pathogens that don't exist anymore. A good example is COVID-19. There was a virus, and immune response is necessary for clearing that, but there were a subset of patients that died, and they didn't die because of the virus itself. When they died, they couldn't find virus there, but what they could find, it was this overactivated and dysregulated immune system that was actually killing the tissue, and killing it in a figurative way. So there we have these cells, and the nice thing is that these cells, there is very orchestrated, right? So you have a lymphocyte there, which will have memory and remember what they're responding to. And then we'll have a dendritic cell, that is another type of cell, that will present either a pathogen or a component of yourself or something vascular that we will discuss that will trigger this damage. So then this is not as simple as it is, because it's very well coordinated, these cells need to make a lot of soluble mediators that reach everywhere. Many of these are cytokines, many of those are called different names that we won't go into. But the bottom line is that this orchestrated immune response is necessary for survival. And if everything was under control, then we wouldn't be studying anything, right? So why are we attempting to investigate this in the lab, and in particular in cardiovascular disease? So we're doing that because, as I said before, we have the heart over there where you can see, and you heard a lot of the physiology and what can go wrong. Mutations can go wrong that perhaps or perhaps not lead to inflammation. But there are also a lot of conditions. If you have a heart attack, we heard before, where you have an injury and you need that response and healing process. So all this is coordinated, and that's what we're trying to attempt to answer in the laboratory. So why? Because patients with cardiovascular disease, they all have increased of those mediators that I told you in the previous slide, those cytokines, or so-called cytokines. And it's thought that those patients that have that systemic chronic activation of the immune response and inflammation have worse prognosis for heart disease. So then what happens is that these two cytokines that were made by these cells in response to something that we still don't know, when they were blocked in clinical trials, they said, well, then inflammation will be resolved, cardiac disease will be resolved. But the result is that there's a lot of people with cardiovascular disease, and when these inflammatory molecules were targeted, then they didn't have any benefit in cardiovascular disease. What is this telling us? Can anyone guess what happened? So perhaps what happened is that that's only the tip of an iceberg. So those cytokines, those soluble mediators are what we see. But behind that, there's this orchestrated immune response that is resulting in that, and perhaps that's what we need to understand. And that's what we're trying to do in the lab. So what we know is that if you have immune cells in your heart, because we only have one heart and it has limited regenerative capacity, the immune cells, as I show you in that skin cut, they are helpful at the beginning, but then if they're dysregulated, they build up, and that ends up damaging the heart and being bad for the heart, so you get a tired heart. So you can actually look at this in the lab. So these are cross sections of a heart. If you have a heart and you cut it in half, you can make slices, you can use antibodies that can detect what a T cell or an immune cell is, and you can find in there. And do you see any differences in those two? Yes? I can tell you the differences. So in that one, you'll see a lot of purple circles. Those are T cells that are in the heart, and those are the hearts that are very unhappy. So you can also image this. You can take cells from blood from heart failure patients or mice that are sick. You can perfuse them across endothelial cells, vascular cells that are from coronary vessels. You can mimic the blood flow with a pump in there. And then you could do all the mechanisms that you want. You don't need to pay attention to what those molecules are, but you can really find out if the T cells can make it to the heart, they will interact more with those vessels, and you could image that. So this is one example, hopefully. So this is one example, right, of some work that was done by somebody in my laboratory, Tanya Nevers. So those are T cells from a non-heart failure patient on human coronary endothelial cells flowing by. And what you can tell is that they bind in way less numbers than those T cells that come from the sick patients. You can also model this in mice. So in mice, you can perform surgery. You can ligate the aorta there. And what you're doing there is that you're making your heart work harder, kind of like when the heart in a heart failure patient is not working. And by doing that, you can mimic a lot of things that happen in that remodeling of the heart, including inflammation. So you could do surgery in mice, you could track them over time, and then you can do any experiments that you want. You could dissociate the tissue and look for immune cells. You could do sequencing, you could do a lot of things. And by doing this, one can see that if you do that surgery, you do see T cells in the heart. Those are those purple cells. I told you about the immune response, how they are activated and proliferating. So you can see that in the lymph nodes, there are a lot of enlargement and proliferation of the cells. And then you can see that that correlates with those pink hearts. Pink is usually, as my daughter would say, a beautiful color. But if you see a lot of pink with this staining in
PSGCAS and Saxomer PQC. We kindly request Dr. Satyamangala Nagaprasad and Dr. Rajashekharan to chair and moderate the session.
Thank you so much. So it's an honor and pleasure to chair this session with my close friend and colleague, Dr. Rajashekharan, and my honor to also introduce Jonathan Kirk today. I've known Jonathan for a long time, and I think if I say more, I think I'd be disrespecting the introduction that he got already. So I think let me go ahead, and Jonathan, you could go ahead with the talk.
All right. Can you hear me okay? No. All right. No? Louder? Quieter? All right. Good morning. Vanakkam. I am honored to be here today and talk to you a little bit about my journey and a project we have in our lab looking at a protein called BAG3, BAG3. And let's see if this works. It does. So here are some of my disclosures. And so Sakti told me to share a little bit of my background and history, so I thought I'd start off pretty early. Here is a picture of me. I don't know how old I am here. I'm the one in the Batman pajamas. And so when I was born, neither of my parents had been to university. And when I was about 5 or 6, my father decided he wanted to go to school, and he went to pharmacy school at Washington State University. And my parents didn't have very much money, and so while he was in school, my mom worked at the hospital. They didn't know what to do with my brother and I during the summers, and so they stuck us in a storage room at the hospital, surrounded by IV poles and EKG machines and so forth. And so that's how I spent my summer, in a storage closet at the hospital. And I think probably from osmosis, I became interested in medicine and science, just being around all the equipment and instrumentation. And then eventually, I actually ended up going back to that same school that my father went to get my degree in bioengineering years later. After I finished that, I decided I really loved research. I'd had some experiences as an undergraduate asking questions and thinking about questions that nobody had the answers to. I thought that was exciting. And so I figured this is what I wanted to do with my life. And I went to University of Pittsburgh for my PhD in bioengineering. This is pictures of me. My wife and I drove across the country from Seattle to Pittsburgh for my PhD in bioengineering. And while at University of Pittsburgh, I worked with this man here, Dr. Sanjeev Shroff. Dr. Shroff was my mentor at Pitt, and he was really a fantastic mentor. He got his biotechnology degree in electrical engineering in Kanpur. And Sanjeev really taught me how to ask questions and think about science, and he actually taught me how to be a phenomenal writer. His ability to write, even though English wasn't his first language, really astounded me because he had to be so specific about what he was saying. While I was getting my PhD, I also was supporting my wife and my child at home, and so I needed a second job to support them. And I worked at night as a clinical engineer at University of Pittsburgh Medical Center Hospital. And so I would spend the days in the lab and then the nights at the hospital working as a clinical engineer. And it was also during this time that I became highly addicted to coffee. And working with patients and helping families really sort of made me interested in asking very translational questions scientifically of how could we actually take our findings in the lab to the patients one day. And so because of that experience, I really wanted to go into a clinical environment for my postdoc, and I went to Johns Hopkins Cardiology Division to work with this man, Dr. David Cass, who was my mentor as a postdoc, and he really taught me how to think about questions in a clinical sense, in a translational sense, so that we could one day take what we've found and put it into patients. And then 2015, 2016, I started my lab at Loyola University in Chicago. My lab uses biophysics and proteomics, as well as animal models and human tissue to answer these questions about what goes wrong in the human heart and how can we fix it, what goes wrong in the human heart in disease, and how can we fix it? What new therapies and directions of inquiry can we find? And this is a picture recently of me and my lab at a wedding for one of our members. And since becoming a PI, the people in my lab, the students, the graduate students, the postdocs, the undergraduates, the trainees, they're the ones who are responsible for everything you're going to see, everything I'm going to show, and any success that I've had is due to them. Okay, so let me talk a little bit about a project that we have going on in the lab. Sakti mentioned that the heart beats constantly. Once a second, every hour of every day, every year of your entire life. It can't ever stop. It can't take a break. It has to keep going constantly. And it's this muscle that's pumping blood throughout your entire body all the time, right? Imagine taking a weight and lifting it once a second and not being able to stop all day, every day for your entire life. That's what your heart has to do. And the proteins that make that up, the actual motors that drive that contraction, are called the sarcomere. So the sarcomere is the structure inside the cells of your heart that are actually responsible for contracting and generating that force that allows the muscle of your heart to contract and pump blood throughout your body. So without the sarcomere, without those proteins operating appropriately, there's no pumping of blood and no life. And these sarcomeric proteins, because they're having to contract once a second, every second, your entire life, this is going to put them under immense mechanical stress, right, over the entire time. And these stressed proteins that make up the sarcomere are eventually going to start to degrade, right? They're not going to operate the same way. Just like any machine, just like any motor, it's not going to last for forever. At some point, the parts are going to need to be replaced. But as Pilar said, the cardiomyocyte is terminally differentiated. You can't just make more of them. And so you have to be able to keep repairing this sarcomere inside the cell constantly your entire life in order to be able to continue to contract and pump blood effectively. So this sort of raises the question, how do you replace these sarcomeric proteins, these motor proteins, while the heart is actually still contracting? It doesn't stop. And so the concept here is sort of like what I said is the title of my talk, is it's like repairing the engine of your car, but you can't stop driving. Right, so how do you do that? That's an incredibly complicated procedure, and it's going to require someone highly specialized in order to coordinate all the effects of how this is going to happen. And to draw it back to human disease, if we think about heart failure, so heart failure is when the heart becomes too weak to pump blood throughout the body. Eugene Brunwald showed this in 1967, that essentially heart failure is a weakening of the heart muscle, right? And so this is showing force here in normal animals and then those with heart failure. And so the fundamental problem at the center of heart failure is a mechanical one, is that the myocytes don't generate enough force. And again, like I said at the beginning, that force generation comes from the motor proteins in the cardiomyocyte and that make up a structure called the sarcomere. So this is a little animation of how the sarcomere works. Essentially, it is an interdigitating structure of actin and myosin filaments, so these thick and thin filaments. And the myosin filaments walk across the actin filaments and pull the two sides of the sarcomeres together. So you can see that here on the two ends, you have what are called Z-discs. And these Z-discs then are connected to other ones, and a bunch of these in series all together, as they're pulling together like this, that's how they generate force. So this is the sarcomere that's actually responsible for the force generation inside your cardiomyocytes, and thus the pumping action of the heart. And when you take all these sarcomeres and you line them up inside of a cell, and you line up all the myofibrils and you pack them together into a cardiomyocyte, you get these, they line up here. All the Z-discs, they line up with each other, and you get stripes. And so if you look at cardiac muscle, it has these stripes in it, or also called striations, and that's why cardiac muscle is called striated muscle, is because you see these stripes from the repeating sarcomere structures. We can also measure how much force the actual sarcomere can generate. Okay? If we take an individual cardiomyocyte from a human patient, and we take one myocyte, one cell, shown in this picture here, we can attach it to very, very tiny pins. On one side is connected to a force transducer that can measure how much force is produced, the contraction strength, if you will, of the cell. And the other side is just a stationary pin. And then we take and remove the plasma membrane, and we can directly activate the thin filament with the ion calcium. And so when you take the cardiomyocyte and you measure force, it's just sitting there relaxed at first. And then we introduce more and more calcium. And as the calcium concentration increases, it activates that thin filament and allows myosin and actin to generate force. And as we increase the calcium concentration, we generate more and more force until we get a curve that looks like this. And this tells us the ability of that sarcomere to generate force. And it's been known for many years, about 3 decades, that in heart failure, there is a reduction in the force-generating capacity of the sarcomere, which makes sense. Like I said, it's a weakening of the heart muscle. And so if you look at this curve here, here's human patients, non-failing and failing. You can see the decrease. It happens in pig models of heart failure. It happens in mouse models of heart failure, and it happens in dog models of heart failure. It's been shown and reproduced over and over again. The problem is nobody really knows why. And so to answer this question, we took our own patients from Loyola University Chicago and looked at their cardiomyocytes. And we were able to reproduce what had been shown over and over again in all the other models. But now we can ask the question in these human patients, why is this? Why is it that the heart muscle gets weaker? And as I said, the hypothesis here is that there's a problem with that sarcomere turnover, right? So how do you turn over those sarcomere proteins? What's wrong in heart failure? And we looked to see whether or not there was any indication that the sarcomere wasn't being turned over appropriately. And one way you can look to see whether or not a protein, which is supposed to be degraded and replaced with a new one, is old and needs replacing, is that it is tagged by the cell with a little post-translational modification called ubiquitin. And so we can take a look in these human patients, and we find that there's increased ubiquitination of the sarcomere. You can see these stripe patterns that I said before, because it's striated muscle. There's an increase in ubiquitination of the sarcomere proteins in heart failure, indicating that indeed there's a problem turning over these proteins in human heart failure. They're forming and getting worn down and not being replaced in the sarcomere, which is going to lead, just like an engine that isn't being well cared for, it's going to lead to problems, and your car is going to eventually break down, just like these patients have heart failure. And the reason for this breakdown is the protein called BAG3. And BAG3 coordinates, it's the mechanic that coordinates the care of this engine. So it sits at, I told you about the Z discs, the side of each sarcomere. When you look at a cell, you can see this as lines going up and down throughout the entire cardiomyocyte. And BAG3 sits there waiting for proteins that need to be turned over, where they jump over and grab that protein in order to turn it over and replace it with a new one. The problem is that in human heart failure, there is a decrease in the amount of BAG3. These patients lose BAG3, they don't have enough of it. And in fact, if you look at the individual patient level, what you see here is that the patients who have the highest levels of BAG3 have the highest levels of force production. The patients that have the lowest amounts of BAG3 have the lowest force production. So there's this correlation at the patient level between BAG3 and the ability to turn over the sarcomere and the actual contractile ability of the cardiomyocytes. Well, this is fine. We can do this. We can see this in patients. The problem is can we fix it? Can we reverse this and turn over those proteins correctly? And we can't just try this in people right away. We've got to try it in a mouse. So we're going to try to treat a sick mouse that has heart failure with BAG3 and see if it fixes this problem. And we used a myocardial infarction model of mouse. This is where you tie off the LAD, and so they have like a little heart attack. And then we wait 8 weeks, and they develop heart failure, shown here as contractile dysfunction. And then eventually, you're injecting, we give them a gene therapy for BAG3. So the BAG3 protein is too low. We increase that protein level here at 8 weeks, and you can see it rescues the heart's ability to pump blood. So now the actual pumping action of the heart is restored. The question is, what does it do to the sarcomere? And I told you ubiquitin is the indication that there's too many proteins that aren't being turned over. And here you can see in our mouse heart failure patients, they have too much unturned over sarcomere proteins indicated by this increase in ubiquitination. But when we give them a gene therapy for BAG3, BAG3 is able to come in there, coordinate the turnover of these sarcomere proteins, and restore ubiquitination. And that restored turnover of the sarcomere proteins is also able to have an effect on function. And so here is the force production in black shown for our sham mice and red shown for the heart failure ones. When they have heart failure, again, their force production is reduced, their heart is weak, but when we give them a gene therapy for BAG3 and it performs proper turnover of the sarcomere, we restore normal function of the sarcomere. It's able to generate regular amounts of force as if the mouse is healthy. Okay, so we've shown now that BAG3 is able to take out the trash, all right? It's able to collect those proteins that need to be turned over and help to repair the sarcomere structure. The question then is, what happens after this? So there's a couple possibilities. What happens after the sarcomere takes these proteins that are garbage out of the sarcomere? And it relies on this following pathway. Essentially, once you've identified a protein that needs to be turned over, shown here as this misfolded squiggly line, the protein is then taken to a phagophore where you have the formation of an autophagosome, and then an autophagosome which sort of encompasses, it's kind of like putting the garbage in a trash can. After that, it needs to actually get degraded, and it does that by by fusing with a lysosome. And lysosomes have a very acidic interior that degrades down what it is. So the question is, once BAG3 has pulled that sarcomeric protein out in order to be replaced, what happens after that? In order to do this, we wanted to ask two different questions. If you think about these Z discs lined up inside of the cell like I was talking about before, we have this BAG3 pulls out these ubiquitinated garbage and puts them in the trash can out front, all right? But once they have this in the trash cans, there's two possibilities. Does BAG3, one, does a lysosome come to BAG3 to degrade it, right? So does the garbage truck come to each house and pick up the garbage? Or does BAG3 have to take the garbage to a dumpster somewhere else? We don't know what's happening next. In order to figure this out, we did live cell super resolution microscopy imaging in cardiomyocytes where we tagged all these things so we can watch them move around in real time. And presumably, if BAG3 was chaperoning these to some other puncta, some other lysosome, then we would see the BAG3 moving away. And we don't see that here. This is showing live cell imaging of the BAG3, and it's not moving away. So the BAG3 isn't taking the garbage to a dumpster somewhere. Thus, we must be looking at what other lysosomes are doing. And we can track those as well. Let me skip, this is just technical details. Okay, so these little red dots, these are the lysosomes. These are the garbage trucks moving around the cell really quick, picking up garbage and breaking it down in the acidic interior. And you can see them jumping all around here within the cardiomyocyte. And here's another picture sort of zoomed in. And we're showing these Z discs where BAG3 is there with the garbage. That's in the green. And as we were looking at this, what we saw is that if you follow this guy, an individual lysosome sticks at a Z disc, and it jumps to the next Z disc, and it jumps to the next Z disc, each of this happening between 5 and 20 minutes at a time. So the individual lysosomes are going to the Z disc and picking up the garbage and degrading it. But that was just one picture. We developed a particle tracking software in order to take a look and actually follow all of these lysosomes in 3D with respect to the Z discs over time. And so the software identifies the individual puncta, follows it as it goes through, and then places it in locations next to Z discs. And what we found was that sure enough, what we thought we saw in the pictures was borne out in a quantitative analysis, that the lysosomes are actually going to individual Z discs and then hopping over to the next one. So like a garbage truck stopping in front of each of these houses to pick up the trash. The next question, and so here's the picture. So the lysosome stops in front of each house, picks up the garbage, and moves on to the next house. We wanted to know whether or not, what was BAG3's role in this aspect of it? If BAG3 didn't take the trash to the curb, what happens after that? We hypothesized that it would be like if you forget to take the trash out at home, the garbage truck just drives by. And so we did this by knocking down BAG3 with an siRNA. And you can see here them jumping all around. And what we actually found was the opposite. So BAG3, when you don't have it, the lysosomes, I'm going to jump through this data here. The lysosomes actually still go to the Z discs, they just stop there. So the garbage truck pulls up to the house, but doesn't go anywhere if the garbage isn't there. And so I think of this as a conscientious garbage truck, right? So what happens is the lysosome goes to the Z disc, and if there isn't BAG3 there with garbage, it decides to wait. So it sits there, and as it waits, more lysosomes accumulate, and they're not going other places in the cell that need them. All right, I think that means I'm done. Okay, so to summarize, we've found this druggable protein, BAG3, that you lose it in human heart failure, and that causes a problem with turning over the sarcomeric proteins, and that causes contractile dysfunction. And we can do this with gene therapy. We can restore function with gene therapy for BAG3. And BAG3 also regulates lysosomal traffic in the sarcomere. And so these are the people in the lab who are responsible for this project. Tommy, and now Ahmed in the lab. And I want to thank you for your attention, and I welcome 2 questions. They said I have time for 2 questions.
Thank you so much, Jonathan. Thanks a lot. Yes. As Jonathan said, yes. Yes.
Hello, sir. That was a great presentation.
Thank you.
Why is there a decrease in BAG3 in heart failure cells?
That's a really, really good question. So we're actually looking at that now, because the issue is that the cell, if it's stressed, if the heart is stressed, right, under any sort of stress, you'd think you'd want more BAG3. And in fact, the heart is trying to make more BAG3. The problem is that the cellular environment is chewing that BAG3 up, and that's why you don't have enough of it. And so there are caspases and calpains that are activated under stress as well that's tearing up the BAG3, and that's why we need more of it. The cell, though, is correctly trying to make more of it. The mRNA, everything's up. So that's a perfect question. That's exactly what we're trying to tease apart now in the lab, is exactly why it goes down.
Thank you so much, Jonathan. Thanks a lot for an excellent talk. Look forward to the next ones. Thank you. I'll hand over my position of being a moderator to Dr. Rajashekharan.
Yes, ma'am. Go ahead.
Our heartfelt thanks to Dr. Jonathan Kirk for his enlightening session. Now, I request Dr. Kirk. Thank you, dignitaries. Before the next presenter, I have an announcement. All the poster presenters of session 2 and 3 are requested to go to the veranda of this auditorium and post your posters on the boards allotted to you before 1. The versatile speaker for session 4, Dr. Hind Lal. Dr. Hind Lal is the Associate Professor of Medicine in the Division of Cardiovascular Disease, University of Alabama, Binghamton. With his PhD at Indian Institute of Toxicology Research, Lucknow, India, he obtained postdoctoral fellowship from the Texas A&M University and Tom Jefferson University. He is honored with 19 plus awards, including the Research Excellence Award, Postdoctoral Travel Award by Jefferson College of Graduate Studies, and the Best Poster Award at the Texas. He has contributed enormously towards institutional reviewer and to welcome Dr. Hind Lal to share his expertise on the topic mechanisms of fibroblast activation and myocardial fibrosis. We kindly request Dr. Satyamangala Nagaprasad and Dr. Rajashekharan to chair and moderate the session.
Good afternoon, everyone, and it's a great pleasure to introduce my own colleague and neighbor, Dr. Hindlal. In addition to the detailed introduction, I would say one thing about Dr. Hindlal. Dr. Hindlal is a very eminent scientist in the field of heart and cancer. He's very much interested in looking at, his lab is very much interested in developing models for how cancer drugs can affect the heart. Even the normal heart can be affected by cancer drugs. So without further ado, I invite my colleague and friend, Dr. Hindlal.
Am I at will? It's working? Good afternoon, everyone. So I would like to start by thanking the organizer. I'm really privileged and honored, kind of a special treatment we received this morning. So this talk is nicely placed. We had a talk on the immune cells and then on the cardiomyocyte, and this is going to be another type of cells in the heart called cardiac fibroblasts. So I was asked to prepare a slide about myself. So I'm from a small village of Uttar Pradesh, India, and I'm from a farming family, and it was normal routine for us to help in the farms to our parents before and after the schools. And I did my education from my village, and I did my PhD from IITR Lucknow. In 2005, I relocated to United States for further training. Okay. Yeah. And I did 2 postdoctoral fellows, one from Thomas Jefferson University and one from Texas A&M. And thereafter, I was Thank you. And then I was a faculty member at Temple University, and thereafter Vanderbilt University, and now at UAB, Alabama, Birmingham. So this talk is especially tailored for the undergrad level. So that's why I'm starting from the definition. So what is fibrosis? So as you see here, unfortunately, pointer is not working. So heart, you see the red big cells is the cardiomyocytes, the primary cells that beat and generate the power for the pumping out the blood. And in between the immune cells and the fibroblast, and the space in between the cardiomyocytes is called extracellular matrix. And this is kind of healthy heart. So the term excuse me. So, sorry. What's the problem? Okay, yeah. So fibrosis is the generation of extracellular matrix between these cardiomyocytes, and it could be physiological as well as pathological. For example, of physiological, in a case of heart attack, when the blood supply to part of the heart is blocked, lot of cardiomyocytes will die. And as we learned from the previous talk, these cardiomyocytes don't proliferate. So if somebody not have taken over that space, there will be hole in the heart and person will be dead right away. So this is the job taken by fibroblasts to produce ECM to replace that empty space, which is a physiological hypertrophy. But if it's gone unchecked, it will go to the even remote heart, the healthy heart, and making excessive fibrosis and adverse remodeling, and that is called pathological fibrosis. Yeah. Okay. So this is little wordy slide, so I'm not going to read it, I will just talk like this. So traditionally, cardiomyocytes were considered the primary cells in the heart because they beat and generate the power for pumping out the blood. So other cells like fibroblast and immune cells were considered secondary. However, in recent research, and this only become possible when we able to make, I'm not going to detail complex technology, how we make cell-specific models. So it only become possible when we develop fibroblast-specific model to show that even the heart have normal genes in the cardiomyocyte and immune cells. Just making changes in fibroblasts can lead to a cardiac phenotype, suggesting that fibroblasts have critical role in cardiac pathophysiology. So, as I mentioned, the cardiac literature was primarily focused on cardiomyocyte. So until very recently, there was very limited knowledge about the fibroblast role in the heart or even immune cells role. So here is a linear graph of the research papers on the cardiac fibroblast. As you see, most of the research in cardiac fibroblast field has been just in last 10 years. So most of knowledge is just very recent development in last 10 years. So this is another technique. Again, I will not go in the detailing of the techniques. This is the genetic method to color one type of cells. So in this, the method was used to color the fibroblast cells. And as you here, when we see where are the fibroblasts in the heart, so as you see in this one, fibroblast is stained with the red color with the genetic model, and they are everywhere. So this is another method, is called single cell sequencing. So in the previous one, all fibroblasts were stained in only one color, red color. What disadvantage of this technology you see in the dotted red bar, they are fibroblasts, but you see the color of different kind. So this technology have a special power to color all common cells with one color and cells, the different type of cells in different color. So you see all the fibroblasts are not the same color. So there are heterogeneous fibroblasts. So regarding the modeling of the myocardial fibrosis, so there are different models. One good model is the heart attack itself. So heart pump blood to the whole body, also to heart itself. However, in the case, if there is blockage in the artery that supply the blood to the heart, that you see heart attack, and which is a sudden thing. Person is doing something very normal in restaurant, regular life, and got heart attack. So the region that of heart not getting the blood supply, all cardiomyocyte without supply of nutrients and oxygen will be die. And we know that cardiomyocyte don't proliferate. If someone not take that space, there will be hole in the heart. So that place is taken by fibroblast by making scarring. Sorry. So here is a very good example of both physiological and pathological hypertrophy. So as you see here, the thrombus, the blockage of the artery and heart attack. So as first early acute response, there is physiological fibrosis to replace the area that was built by the dying cardiomyocytes. However, the only problem with these fibroblasts, when they started, they get addicted. They don't know where to stop, and they keep going, taking the healthy heart, and that is what called pathological fibrosis. So in the labs, I cannot do it, but I have surgeon in my lab to model the same disease in the mouse model. So he can open the heart cavity, take out the mouse heart, and ligate the LAD, and put back and suture again, all within 1 minute. If you take too longer in this process, mice will be dead. So in the labs, how we study these models, fibrosis. So we make histology sections. And as you see, the brown part of the right side of the sections, which is the dead heart, and this is staining called mesome trichome staining, and this is stain the healthy muscle in the red color. The scar you see in the blue color, which is from this special staining, and which have aniline, and especially detect fibrosis. We can also study the cardiac function through echocardiography the left side of image, you see this waving thing, which is the heart wall, and one wave is representing one beat of the heart. When you see the right side of echocardiography image, that waving is not that clear in this one, and waving is gone. That is very much showing the problem of the heart is not beating that well. So there are different kind of fibrosis. So I had the most healthy heart, which is covered somehow by this technical problem. So then there is interstitial fibrosis that we see half image. So the fibrosis in between the cells. And then there is this replacement kind of fibrosis, which is special to this heart attack model when the bunch of cardiomyocyte has been dying. And there is third kind of fibrosis, which is around the vasculature in the heart, that called perivascular fibrosis. So this is about the fibroblast, what happened to them in response to heart attack. So once again, the most normal image is now covered. So you can compare this situation like the fire station or the police station. In a very healthy situation, if nothing going wrong, so everybody is happy sitting and having their coffee and regular day. But as soon as heart attack happen, for these fibroblasts, this is kind of emergency 911 call. That's what activate them. And once they activate them, they start making the red wings kind of thing, producing loss of extracellular matrix. Oh, very nice. Yeah. Okay, so this is good. In the most left one, you see the green kind of cells, a small one. Those are the happy fibroblasts in a healthy heart. And as soon as they get this emergency heart attack or 911 call, they get super activated and they change their forms, and this change form is called myofibroblast. And when they become myofibroblast, they get addicted, they start producing this excessive fibrosis, and they replace the dead side of the heart, and also they start affecting the healthy side of heart. That's called pathological fibrosis. And they proliferate. Once they become myofibroblast, they aggressively proliferate. They secrete a lot of fibrosis. They also secrete chemicals to invite immune cells to come and take over. Okay, so far, everything was just tailored to the undergrad level. So I'm just finally want to show 2 slides of the kind of research I do in my lab. So how we study, how we discover this molecule have X role or Y role in fibrosis. So the simplest way of thinking this is, like if you have your friend around you, you generally never miss him, right? But when that person is gone from your life, then you start obviously missing your loved one, right? So we use very similar approach for this. So if the protein of interest, I want to know the role of X protein in fibroblast, we take that protein out from an animal. And in scientific language, we call it deletion or knockout. Then we see having that protein or not having, how it affects the outcome of fibrosis. So in this case, my lab had mouse model. We take GSK3 beta out specifically from the fibroblast. All other cells of the body had fibroblast. And so what we see over here, this is trichome staining. The red cells are the cardiomyocyte, the muscle cells, and the blue is the fibrosis. As you see, just taking out one molecule GSK3 beta from the fibroblast, there is much more blue in the right side of the image, saying that this molecule have anti-fibrotic effect, and when this molecule is not there, there is excessive fibrosis. With this, I like to thank organizers again, and I like to acknowledge all the work done by my lab members and support from my family. I have two boys, 10-year-old and 5-year-old, and this work mostly done by Dr. Sultan and Yunjun Guo, and collaborators from various institutions, funding from NIH and HA. Thank you very much. and I will be happy to take questions.
Thanks, Dr. Lal. That was a wonderful presentation. So now his talk is open for questions. We have a couple of minutes for 2 or 3 questions.
Excuse me.
What?
Investigation for diagnosing myocardial fibrosis.
Yeah, so in the lab we use this trichome staining and different kind of markers for fibrosis like collagen 1, collagen 2, fibronectin, ECM proteins.
Can MRI be used to diagnose fibrosis? MRI, cardiac MRI?
MRI, yes. So I'm not expert of MRI, but I'm aware that in the patient setting MRI get used, and yes.
Thank you, sir.
Sure.
Students, we have time.
Yeah, and question can be like career-related question or science-related question.
Are there any additional questions?
Thank you, everyone. I was the only hurdle against your lunch.
Yeah, sorry for the technical glitch.
Yes.
Yeah. Thank you, everyone, for the wonderful attendance and interactions. I believe that it's going to be lunch now, but I think that announced. Oh, felicitation. Wait for a minute, please. Ma'am.
Let's acknowledge the insightful session by Dr. Hindlal with a round of applause. Now I invite Dr. S. Mohandas, Associate Professor and Head of the Department of Biochemistry, to felicitate Dr. Hindlal. Thank you, dignitaries. As the morning session draws to a close, let's take a pause to nourish both body and mind. Remember, as Mahatma Gandhi once said, there is no sincerer love than the love of food. With that in mind, let's break for lunch and savor the flavors of camaraderie and good food. Please be sure to return promptly as we resume our sessions at 2 p.m. Bon appetit.